Thank you for taking time to join us today. Our team is passionate about improving the level of service and safety for the people in our care at OSU Medical Center. We believe that your investment in the Team Steps program can make a significant positive impact on that goal. We are speaking to you today about Team Steps as part of an action plan related to an incident that happened at OSU Medical Center. Unfortunately, errors do occur at our facility far too often, and many of you may have already been involved in events that could have been prevented. Every day, each of you face critical situations. You have the power and the responsibility to do everything you can to prevent negative outcomes for our patients and their families. If you commit to understanding Team Steps and put it into practice every day, you will be well equipped when these circumstances arise. You can make a real difference in the lives of the patients you care for and protect yourself from exposure to situations that could have a devastating impact on your own career. By modeling use of Team Steps, you will also influence future generations of physicians who come to OSU Medical Center for their training.
Team Steps provides specific tools and strategies for teams that are striving to reduce the chance of error and provide safer patient care. A few years ago, Johns Hopkins published a study that said medical errors attribute to an excess of 200,000 deaths in the U.S. every year. Before COVID, the third leading cause of death was medical errors. To put that in perspective, let's talk about the airlines for a moment, another high-risk industry. Before COVID, on average, 100 passengers boarded a commercial flight. In a year, it would take 2,000 or more of those flights to fall from the sky with everyone to perish to equal the 200,000 deaths attributed to medical errors. Now, would you or anyone fly if it was known over 2,000 planes were to crash each year? Medical errors can occur anywhere in the healthcare system. Hospitals, clinics, surgery centers, nursing homes, pharmacies, and even the patient's homes. Errors can involve medication, surgery, diagnosis, equipment, or lab reports. Errors can happen even during the most routine task, such as when a hospital patient on a salt-free diet is given a high-salt meal. Errors also happen when team members have ineffective communication. Team Steps is about providing higher quality, safer patient care. It's proven to work and is evidence-based. More than 30 years of research and evidence have been accumulated on teams and team performance in diverse areas such as aviation, the military, and healthcare. Team Steps was developed by the Department of Defense and in collaboration with the Agency for Healthcare Research and Quality. It has been designed for healthcare professionals. Team Steps provides tools to help improve leadership, communication, problem solving, continuous improvement, conflict resolution, and planning. There are many obstacles that can impair an individual or team's ability to work effectively and prevent errors. Here's a list of barriers to effective team performance. As we go through the presentation and introduce the tools, some of these barriers are going to cross your mind. During this time, let's proceed with an open mind. No barriers. The Team Steps tools highlight the right information to the right people at the right time. As you can see here, the 4 Team Steps skills include leadership, communication, situation monitoring, and mutual support. Currently, you may be using a few of these tools. Using all the tools is not required. Identify those that will improve care and safety in your area. Just a reminder, we are not going to cover everything today. You can find more information on ozone and from the quality department. Jamie will now introduce you to a patient named Jennifer.
As you watch the video and hear her husband talk about their story, think of what happened, what didn't happen, and listen for missed opportunities.
She really taught me how to live and how to love in a way that I didn't really know before. We had a whole weekend planned of activities and making our way back towards the marina, and something went terribly wrong. There was a huge crash and everything went blank. Jennifer was thrown forward and crashed through the cabin door down to the lower galley, and I spent the night in the hospital myself, so I was unaware of what was really going on until the next day. That's when I learned she had a lot of continued complications with her breathing. We had gotten Jennifer to the place where she was now able to speak. She was able to write. And she wrote in big letters that we're gonna make it. And at that point, I had every reason to believe that that was true. We were so excited because Monday morning she was scheduled for a barium swallow test. And that was the last big hurdle. With a green light on a barium swallow test, she was going to go home. I since have become very familiar with a term called TEF, which is a tracheoesophageal fistula, which is basically a hole that establishes itself between the trach and the esophagus. The barium went down her esophagus and then was quickly seen to migrate into her trach and then quickly spread into her lungs. They were blowing her full of air for 6 hours. Instead of it going into her lungs, it went into her belly. They told me that Jennifer was in cardiac arrest for over 14 minutes. She was so oxygen deprived that everything just shut. How is it possible that on Monday morning you have a definitive diagnosis of a TEF, but Tuesday afternoon she's back on a positive pressure ventilator with no isolation and no protection from that hole that they had just discovered? I've since learned a lot about electronic medical records and something that the industry talks about, which is the problem list. Problem list is a idea where you take all of this aggregate information and the computer systems try to organize it. The most problematic condition is sort of forced rank to the top, and then everything sort of in descending order follows thereafter. It's tricky, but it's where electronic medical records have to go, because no human can possibly absorb as they're coming onto a shift or as they're assigned a respiratory case like Jennifer's. I have 4,661 pages of her medical record. One page, one paragraph talks about the TEF. So what did the caregivers know at the most critical time? I don't know. They clearly didn't know she had a TEF. We all go into those environments with a false sense of safety. The truth is, there's so many moving parts. There's so much information. It's not well organized. It's not well communicated. It's not well coordinated. I don't believe for a minute that Jennifer's caregivers were intending to do any harm to her. It's just a case of they didn't know.
As a final requirement for discharge and to start soft foods, Jennifer needed to pass a barium swallow test. During the swallow test, it was discovered that she had a tracheoesophageal fistula, or TEF. Barium had migrated into her lungs and triggered respiratory distress. Over the next 36 hours, she was transferred back and forth between multiple units and caregivers. Her respiratory distress was misdiagnosed as anxiety, and she was given multiple doses of Ativan. By Tuesday afternoon, she was placed in the recovery area as there were no available ICU beds. The decision was made to then put her on a ventilator. The caregivers at the time were unaware of her recently diagnosed TEF, and they simply began ventilation through the existing trach. Over the next 6 hours, they increased the cycle rate and O2 concentration. During that time, there was no documentation of physical assessment, no blood gases, and no end-tidal carbon dioxide monitoring. By 12:45, she was in full cardiac arrest and a code blue was called. She underwent CPR for 14 minutes, resulting in a restored heart rate. Due to the complication of TEF, she had a hyperabdominal extension and lack of oxygenation to the brain. They were able to keep her alive for the next 3 weeks on life support in a non-responsive state. All tests and consults pointed to the same conclusion: massive and non-recoverable brain damage. The decision was made to discontinue life support.
During the video and the report, you probably identified many missed opportunities and things you would have done differently if you had been involved. You may have also reflected on situations that have happened in the past or issues you encounter routinely that could result in some negative outcome. It is terrible to imagine that a life could have been saved if only the right information had been shared with the right person at the right time. As we go through some of the TeamSteps tools, remember Jennifer and her grieving family. Imagine how any one of these tools could have made a difference if it had already been a hardwired practice among all the caregivers, if someone had just stepped up, or if you had been there and were equipped with the right tools. We know a breakdown in communication is often the reason that errors happen. In Jennifer's story, multiple caregivers were involved in her care. We don't know, but can question if a proper handoff was used. Was there a transfer of information during transitions? Was authority and responsibility transferred properly? Was the right information provided to all the right people every time? SBAR and IPASS are tools that provide a structure to ensure all critical information is communicated consistently. If you make handoffs, SBAR, and IPASS part of your daily routines, you will know that you did your part to communicate effectively. Call-out checkback is a very effective tool when you have critical orders or information that must be fully understood. One person verbalizes the information, then the second person confirms they understood by repeating the information back. During an emergency situation, use of this method ensures all team members heard the information accurately and are ready to act on the message. This tool is used routinely during code blues, but can also be beneficial in a host of other situations. The Cath Lab now uses call-out check-back to ensure effective communication during their procedures. Use of call-out check-back may have been of benefit in ensuring key information was understood at critical moments in Jennifer's situation as well.
Another TeamSteps category is leadership, which includes tools you have probably used: brief, huddle, and debrief. These are basic tools that assures everyone knows the plan and is on the same page. In the case of Jennifer's story, there was a plan. Put her on a ventilator. A simple, quick brief by a leader with the right people would have provided the plan. Roles would be assigned as well as responsibilities, such as who is going to do a physical assessment and who is to monitor EtCO2 and take blood gases. In the brief, expectations are established, outcomes anticipated, and possible contingencies discussed. During a brief is the time to share known information, such as in this case, Jennifer has TEF. and was given Ativan. After being placed on the vent, had someone been assigned the role to monitor the patient, they would have noticed the cycle rate and the increased O2 levels. At that point, someone should have taken leadership and called a huddle. A huddle happens when the situation changes and the plan needs adjustments. Like in the brief, roles and responsibilities are assigned and expectations and outcomes are discussed. The leader can be a formal leader, such as an attending, or the leader can be informal. In this case, it might have been the person monitoring the patient. In a brief or huddle, everyone should be comfortable being a leader and comfortable at times not being a leader. Taking a few seconds or minutes to do a brief or huddle can make all the difference to the patient's outcome. We will discuss debrief in a later slide. A brief or huddle helps us to understand the situation. Much like this image, people can see a situation in different ways. They can get mixed messages or not even the right message. Can you see the two situations in this picture? Some of you will see a man's head with a white mustache, and others will see two cottages and a sheep herder wearing a white flowing shirt. One picture, two totally different situations. Sometimes we need support from our peers. Don't wait until someone is drowning to offer help. There is a time to step in, speak up, and help. It's called mutual support. Mutual being the key word.
Mutual support provides a safety net to help prevent errors, increase effectiveness, and minimize strain caused by work overload. What do we know about Jennifer's situation? The team didn't have all the information they needed to make the right decision. Everyone is an advocate for the patient. If corrective action is needed, team members should feel comfortable asserting the corrective action in a firm and respectful manner. The feedback should be accepted in a respectful manner as well. If you see something wrong, say something. Cuss and two-challenge rule are two tools that can be used to communicate a safety issue and stop the line. As the cycle rate and O2 concentration levels increased in Jennifer's situation, someone should have felt comfortable to use cuss and to be an advocate for the patient. Had the team used these tools, they would have benefited from a shared mental model. A shared mental model is the understanding or knowledge about a situation shared among team members through communication. Each team member maintains situational awareness and shares relative facts with the entire team. Communication ensures everyone is on the same page. It is a continuous process requiring relevant input from all team members. Hopefully, at the end of this tragic event, there was a debrief in which there was time to identify what went wrong, what went right, and what can be used next time. Unfortunately, in this case, there was a debrief. However, it was in the presence of risk management and a team of lawyers, and possibly in front of the family. In situations like Jennifer's, OSUMC leadership will facilitate a formal debrief. We recognize that incidences with severe outcomes, a formal debrief should be conducted. Everyone should have the opportunity to be heard in a safe environment. A debrief allows exploration of opportunities for improvement. Provision of employee assistance will be provided as needed. Debriefing provides feedback, improves employee engagement, and provides confidence. This process was developed in response to an event where a patient attacked an employee, but can be used outside the setting of workplace violence. Team STEPS tools are evidence-based, and they've been proven to promote patient safety. However, if the organizational culture does not support the use of these tools, there will be conflict and chaos, maybe more so because some will try a tool and others may be angry or offended. A culture that supports these tools finds that anybody can be a leader and everyone is an advocate for the patient. It promotes an atmosphere of empowerment to speak up and it promotes respectful communication in both giving and receiving of information. A patient safety culture is a culture that we watch out for and we say, "I've got your back." It's a culture of safety that is paramount for our patients and team members.
We hope you will take the information you've heard today and put it into action. We encourage you to work with your peers and leaders to identify specific tools that you will use in your daily routines and then hardwire them so they will remain in place long into the future. Remember to also include nurses and ancillary staff in your plans so all the right people will be involved. Our patients and their families deserve the best care, and we believe that includes use of these critical TeamSteps tools. We thank you for your time today and welcome any feedback or questions you may have. TeamSteps resources are available on Ozone, and our team is happy to assist you with education or program development. We encourage you to reach out to us if we can be of help. Thank you. Dr. Alex, I have to apologize. I skipped a slide and it had a lot of good content. We'd like to backtrack so everybody has the opportunity to hear the information.
Of course, Jennifer, please go ahead.
Okay, thank you.
This brings us to the next TeamSteps category of situation monitoring. The process of situation monitoring is to continually scan and assess a situation to know what is going on around you. This includes the patient, your coworkers, environment, and progress towards the goal. When maintaining situation awareness, it ensures all team members are on the same page. Back to Jennifer's story. We can only speculate the situation, but we know the ICU was full and Jennifer was placed in a recovery area. The team probably had a high workload, there was stress and possibly fatigue. A TeamSteps tool used to monitor the situation is STEP, S-T-E-P. S stands for status. Did the individuals know the status of the patient, the physical exam, history, vitals, etc.? T is for team members. How are the team members functioning? Are they tired? Maybe being pulled in multiple directions? Also keep in mind the team members' skill set. Were the right team members present with the right skills? What was the environment like? That's the E. The patient was placed in a recovery unit. Did they have the right equipment for the situation? Could the EMR have been easier to read? Things like that. The P in STEP represents progress towards the goal. Was the status of the patient appropriate for the goals and plan? When the situation changed, was a huddle called and a new plan made? Situation monitoring also includes I'm safe. These are personal factors that contribute to the performance of yourselves and other team members. Is there a team member dealing with an illness? Are you taking medications that may affect your performance? Is someone involved with alcohol and drugs? Basic necessities such as eating and taking a restroom break are personal factors that can affect safety. Next is cross-monitoring. This is watching out for each other and feeling comfortable to monitor the actions of others to catch mistakes and oversights. If you see something wrong, say something. You also have to be willing to listen when a potential safety issue is brought forward. In Jennifer's story, there are several times someone should have spoken up. Why did they not? This brings us to the next skill called mutual support.
Okay, thank you. We apologize for that change in plan.
No worries. Are there any questions out in our GME community? Check the chat here. Okay, well, thank you so much. We appreciate the team support, and quality improvement, patient safety, and teaming. I think this is a great reminder of how well we work together in the interest of our patients and the safety of each other. So thank you once again, and look forward to seeing you around the hospital. Thank
Very
you.
good. Thank you. Appreciate the opportunity.
All right. Thank you, everyone.